Hello everyone, today we'll be talking about laryngeal carcinoma. So the epidemiology. So basically one thing you need to know even before we get here is laryngeal carcinoma refers to carcinoma of the larynx. It's more common in males and the age of onset is between 40 to 70 years. This is the most common age of onset. Then etiological agents or risk factors, smoking and alcohol use. These are the two major risk factors. Precancerous lesions such as leukoplakia or laryngeal papillomatosis in adults, or irradiation of the head and neck region, and rarely infection with HPV, variant 6 and 11. Diet rich in salt, preserved meats such as nitrosamines and dietary fats. So classification of laryngeal carcinoma, these are classified according to the location in relation to the glottis. So we've got glottic carcinoma or vocal cord carcinoma, which is the most common form, approximately in 60% of cases. Then supraglottic CA, which is approximately 40%, and subglottic, which is just 1% of the cases. And laryngeal carcinomas are almost always common cell cancers. So this is the TNM classification of laryngeal cancers. And if you want to look at that in more details, you can go through this link. I'll put it in the description. Clinical features of laryngeal carcinoma include hoarseness, change in voice, and basically when you'll be taking history, there'll be progressive hoarseness of voice. Then foreign body sensation, dyspnea, dysphagia, stridor, which is due to airway narrowing, aspiration while eating or drinking, and unexplained hoarseness of voice longer than 3 weeks should always be investigated by laryngoscopy. So, diagnostic techniques. You can do a direct laryngoscopy with trivial, irregular, nodular, or ulcerative lesions. You can do imaging such as CT scan, MRI, and or ultrasound of the neck to assess the tumor size and spread to surrounding tissues. Choose lymph nodes. You can do a laryngoscopic view of glottic carcinoma in T1A and glottic carcinoma T1B. Treatment. So in the early stages, you do a radiotherapy or transoral endoscopic laser resection. Advanced stages with lymph node and or distant organ metastasis, you have to do a laryngectomy. And voice rehabilitation after laryngectomy. So the prognosis, glottic carcinomas have the best prognosis, which is 5-year survival rates of approximately 90%. And the 5-year survival rate drops drastically when the supraglottis and a subglottis are involved. So basically, glottic carcinomas have a very good prognosis. So in summary, laryngeal carcinoma is a malignant tumor of the larynx that occurs most commonly in older men. Smoking and alcohol consumption are the most important risk factors. Based on the location of the tumor, laryngeal carcinomas may be classified as glottic involving the vocal cords, supraglottic or subglottic carcinomas. Glottic carcinoma, which is the most common form, presents early with hoarseness and is usually associated with a good prognosis. Supraglottic and subglottic carcinomas present late and are therefore associated with a poor prognosis. Direct laryngoscopy is required to visualize the tumor and assess vocal cord mobility. Imaging of the neck may be required to determine the extent of the tumor and check for spread to cervical lymph nodes. The method of treatment depends on the site and stage of the tumor. Early stages are treated by either radiotherapy or endoscopic laser resection with the goal of preserving the voice. However, late stages require some form of laryngectomy. After laryngectomy, patients must undergo voice rehabilitation, which involves using vibrations in the pharynx to produce speech sounds. So basically, that's all about laryngeal carcinoma. Thank you for watching.